Good morning, Dr. Lang.
My name is Dr. Lang, and I would like to welcome everyone for our series of lectures. The first one today would be about post-traumatic stress disorder and complex post-traumatic stress disorder. I would like to introduce Dr. Robert DeWors now, who would introduce our own esteemed colleague, Tamar. Dr. DeWors.
Welcome, everyone, to this, our first in a series of lectures focusing upon the appropriate diagnosis and treatment of complex PTSD and borderline personality disorder. As we know, our DSM-5 does not include the diagnosis of complex PTSD, but it is included in the ICD-11 of the World Health Organization. And I think that lack of inclusion tends to make us not as sensitive as we might well be to understanding the complexities in treating this condition. And the notion is that the more understanding we have around the clinical presentation and treatment, the more effective we can be in treating this very damaged population. So it's with my great pleasure to introduce Tamar Newmar. Tamar is a psychologist in Germany, and she lectures extensively throughout Europe on this topic. We enjoyed her presenting in a series a couple of years ago, and there was such demand, we decided to use this format in which we're recording the lectures and make them available to people upon demand, and we're in the process of organizing this now. So the format for today will be a lecture by Tamar, and again, we're very grateful that she's sharing her wisdom and her enthusiasm with us. And we will leave some time towards the end for some questions. So I will stop rambling, and again, we very much appreciate your participation and feedback. This is a very important topic, as you know, and thank you.
Thank you, Robert, for introducing me. I'm Tamar Neubauer, and I'm from Germany, so excuse my accent and any mistakes I will make throughout the lecture, as I'm not a native speaker. So without further ado, let's start into the presentation. I tried to put together a presentation about PTSD, complex PTSD, differentiated it from borderline personality disorder, and we'll focus more about complex PTSD, saying what is different and why is it important to diagnose complex PTSD and how it will help us in the treatment later. Okay, yeah. So what is complex PTSD? As Robert said, we there's no official diagnosis of complex PTSD in DSM-5. In DSM-5, oh, I have a mistake here. So you can diagnose PTSD, like a normal PTSD, with or without dissociative symptoms or dissociation. So that's what DSM-5 included in a new version to describe the complexity some clients show. ICD-11 has introduced complex PTSD as a separate diagnosis as a result of the research that has been done in the past 30 years, showing that PTSD, as it was described in ICD-10 or DSM-4, was not including every aspect or every symptom clients were experiencing, and it was making it difficult to treat populations of more severely affected clients, so to say. Yeah, so complex PTSD in ICD-11 is a post-traumatic stress disorder. It's like a normal post-traumatic stress disorder that describes more complex reactions and that are usually shown by clients who have been exposed to chronic trauma. Not always, but mostly. People exposed to chronic trauma or severe man-made trauma develop or tend to develop more complex symptomatology. And as I said, this addition of the diagnosis is supposed to lead to a better treatment and lead to development of better treatments for this population, or effective treatments for this population. As we will see later, because all the manuals that we have now, PE or CPT, they have been all developed for clients for normal PTSD, and the clients with complex PTSD have usually been excluded from the research. So you can't really say whether the treatment manuals we have today or nowadays can be used for complex PTSD clients. It is not irrelevant. Yeah. So the first iteration of PTSD comprised of three symptom clusters, right? The re-experiencing of trauma, like flashbacks, intrusions, or nightmares, avoidance of reminders of trauma-related stimuli, like this avoidance behavior that is also a mask criteria for PTSD, and hypervigilance for like the startle reaction or excessive attention to potential threats. So these are like three main symptoms of normal PTSD that is also that we also need for complex PTSD. And the new symptoms, the symptoms included in DSM-5 have grown to include like 20 symptoms and 4 symptom clusters that leads to, that makes more difficult to diagnose, you can say, the PTSD, as it comes up to 600,000 possible constellations you can diagnose PTSD now. So it has become also very complex. So that's one thing. So I will go over the symptoms that you need to diagnose, diagnose the criteria of PTSD first. So one thing is exposure to trauma, the A criteria, as we say. So you need to have been exposed to an actual threat or exposed to actual or threatened death or serious injury. Or sexual violence in one or more ways, right? Like direct experience, witnessing, learning that the traumatic event occurred to others, mostly to your people close to you, not someone in in the world, but it's usually your friends or family. And experiences repeated or extreme exposure to aversive details. And this includes usually police officers watching children, like pornographic material, for example, or the doctors coming to scenes where people have been mutilated, and after like big car crash or like big disasters where they have to witness extreme exposure to details you usually do not see and are very aversive. And it can lead to, if it gets massive and usually like if you get repeatedly exposed to those details, those people can develop PTSD. So we have those 4 ways of experiencing it. And when diagnosing PTSD, the A criteria is one of the most important ones, because in difference to other mental disorders, PTSD is the one disorder that really needs exposure to actual traumatic stress. So if someone has not experienced trauma in the way it is defined in DSM-5 or ICD-11, you cannot really go on diagnosing the trauma. And why I'm accentuating it so much is that usually it happens quite often that things that are not traumatic in the sense of DSM-5 are called trauma in like people call it trauma. Sometimes psychologists call it trauma as well, depending from which school they are coming. So it is important to make clear that there are like traumatizing experiences in life, or there can be traumatizing experiences in life. They don't have to lead to PTSD though, and to differentiate that. And those other traumatizing experiences can lead to other disorders, maybe depression, maybe personality disorders, but they would not justify diagnosing a PTSD. So we need for like PTSD, this was kind of extreme stress, death, injury, sexual violence, and things like divorce, emotional abuse, disappointments, mobbing, etc., etc. Things that can be distressing and traumatizing. And I don't want to say they are not bad at all, but they would not justify the diagnosis of PTSD. That is really important. Okay, so then after that, after we have like a trauma, the A criteria, we can go on with intrusions. This is the presence of one or more of following symptoms associated with the traumatic events, like you have intrusions, flashbacks, nightmares, bodily intrusions as well. There's also a mask criteria, so you have to have this reliving of trauma in form of intrusions. Intrusions, we call intrusions these images or sensations that clients experience where they see the trauma happening in front of their inner eye again. And you would say flashback is an extreme form of intrusion where clients lose the contact to reality when they are re-experiencing the trauma, and they think they are really, or the trauma is happening to them again, really, while losing contact to reality and not knowing where they are and who is in front of them. So it's like a very extreme form of intrusion. Intrusions are more normal or common, and flashbacks happen more rarely, but they are much, much more dramatic. You will not oversee a flashback, so to say. Intrusion, yes, because intrusions happen in front of the client's eye, and you don't have to notice that. The next criteria we need is avoidance behavior. So avoiding distressing memories or external reminders. That is clear. And the D criteria is that clients have alterations or negative alterations in cognitions and mood associated with traumatic events. So after the trauma, their mood and cognitions have changed. It's also like inability to remember important aspects of trauma. This is very common for PTSD. And persistent and exaggerated negative beliefs about oneself, others, and the world. So the trauma has drastically changed the way clients see themselves, see the world, see other people. So they are more afraid, they have lost their trust in other people, they feel insecure everywhere, and they think also like about themselves, that they are not capable to stand up for themselves or to fight for themselves. So they feel very weak and as if anytime anything could happen to them. So this notion we have that we are secure in the world, in our life, gets lost. It's very typical. Yeah, that's it. And the symptoms have to be persisting longer than 1 month. That's a time criterion. These are the new ones. This in DSM-5, negative alterations in mood and cognitions has been added in DSM-5 in difference to DSM-4. Expanded hypervigilance to include problems with anger and reckless behaviors is new, and dissociative experiences, derealization and depersonalization as a subtype of PTSD is new. So we didn't have it in DSM-4. So that's how DSM-5 describes the normal PTSD or PTSD with or without then dissociative experiences or symptoms. Let's see how it is in ICD-11. Yeah, so ICD-11 was released in 2018 and it's more for, like DSM-5 is more focused on research, and ICD-11 is more trying to be helpful for public health and be useful. So it tries to simplify diagnosis and treatment, application and planning. Yeah, and it tried these in ICD-11. They tried to recognize the heterogeneity of the trauma clients and introduce the complex PTSD as an extra diagnosis. So that was the reason why they did it, and maybe DSM-5 did not. And complex PTSD will be under the chapter under the chapter of disorders specifically related to stress. So it will move from anxiety disorders to stress-related disorders. This is also very important because we have to say that PTSD is not an anxiety-related disorder only, it is a stress-related disorder. And to define PTSD as an anxiety-related disorder leads to, or has led until now to lack of research with regarding other emotions that are really relevant. For example, for complex PTSD clients, mainly as shame and guilt and helplessness, and they dominate emotionally the image of and the experiencing of those clients. So using the interventions that have been developed to treat anxiety disorder, like prolonged exposure, for example, does not help or doesn't help enough clients with complex PTSD who experience other stress-related emotions. So it was a very important shift, to say. Yeah. Yeah, so the new to diagnose complex PTSD according to ICD-11, you need to meet the criteria for normal PTSD. And in addition, that's very important, in addition, you have to have problems in emotional regulation, in self-identity, and relational capacities. So a complex PTSD is defined as a PTSD in a more complex form where you have a client show emotional regulation problems that usually can be seen as maybe misusing of alcohol, self-mutilation, suicidality, aggressive outbursts, dissociation, and so on and so on. Self-identity, so clients feel have a negative self-identity. They feel bad and worthless, usually because what happened to them. And they have problems in relationships and try to avoid any kind of relationships. They have difficulties finding partners, finding friends, so they tend to isolate themselves. This is the tendency they have. So if clients meet those three dimensions or criteria, in addition to meeting criteria for normal PTSD, you can diagnose a complex PTSD. Most investigations say that complex PTSD typically emerges from sustained traumatic experiences and like chronic man-made trauma. But there are tendencies that show that that doesn't have to be always the case. We see that clients who like usually clients exposed to chronic trauma develop chronic PTSD, but we also see clients who have been exposed to single trauma, maybe have been raped once, or have been robbed maybe once in a bit more severe way. They may also develop symptoms of chronic complex PTSD. And it is more reasonable to say that vulnerable individuals have a higher risk to develop complex PTSD no matter what the trauma, and more resilient, well-supported people can cope with the trauma better and do not or would develop normal PTSD or neither disorder. I have seen clients who have been sexually abused in childhood over many years, or let's say 2 clients, they have been sexually abused by their fathers in a very similar way maybe, and one had a very complex symptomatology, and the other one was really well off, had a simple PTSD, no dissociation, no self-mutilation, no suicidality at all. So it doesn't have to be, but there's a big tendency, of course, that severe chronic man-made, especially trauma, leads to complex symptomatology or complex PTSD. As you may have noticed that as when I described complex PTSD and especially those 3 additional symptoms, they sound very familiar or similar to borderline personality disorder, because borderline clients do harm themselves, they are suicidal, they do dissociate, they have aggressive outbursts, they have problems with identity, they have problems with relationships. So it sounds very similar at first glance. And it was a long time a debate over that topic. And many people said it's the complex PTSD is a normal PTSD with a comorbid borderline personality disorder. But after a long time of studies and decades of studies, now it is clear that it's not the same thing. It is really different. These are 2 different disorders, and they are very clearly distinguishable from each other. Here you have an overview. So, like, to compare normal PTSD with complex PTSD and with borderline personality disorder. So, normal PTSD is like clearly more fear-based, includes reactions of anxiety, avoidance, and hypervigilance. Complex PTSD emerges typically from more chronic trauma. People have problems with emotion regulation, have negative self-identity, as I said, and relational difficulties or avoidance of relationships. And in difference to borderline clients avoid to be alone or be left alone. We know that. That is not typical for complex PTSD clients. They don't have any problem with being alone. They love being alone or to be alone. Borderline clients have unstable self-identity. So the self-identity switches from feeling bad or negative to feeling really or thinking really well about oneself. So it's more unstable. Whereas with complex PTSD clients, you have negative self-identity throughout. It does not change. And complex PTSD clients would say, I am a bad person because that happened to me. It's also related to trauma usually, or I'm a bad person because I made it or let it happen and did not do anything against it, or so they feel guilty and ashamed for what happened, and that affects their self-identity. Whereas with borderline clients, it's more like, I don't know who I am, I react differently. So it's more this instability factor. It is not the case with complex PTSD clients. Borderline clients have unstable and intense relationships and that change a lot. And it's not the case with complex PTSD clients. They either don't have any, or if they have, they are stable. They stay with the partners, even if they don't like them, even if they are not ideal. They stick to them as it gives them security, and they think, I will not get anyone else anyway, so what's the sense in leaving him? That usually changes after we have done the trauma treatment. And impulsivity, that is typical for borderline clients. They tend to drink a lot. They tend to have impulsive sexual contact. They tend to have impulsive eating and shopping habits and so on and so on. This is not typical for complex PTSD clients. They are not impulsive. They are more regulated. They are they are not impulsive. You notice the difference when you have contact with them. So that would be the main differences. Of course, we have comorbidities, and you can have borderline personality disorder with a comorbid complex PTSD disorder, where it gets more complicated maybe because you have both, but you can clearly differentiate them from each other. And it is also not unimportant to differentiate BPD from complex PTSD, as those clients seem also similar at first glance when you meet them maybe on the inpatient units when they are in crisis. Complex PTSD clients in crisis, at first glance, you may see, or also chronic complex PTSD clients may look like BPD clients. Not because they are self-harming, they say I'm suicidal, I hate myself, and so on. And but you have to look closer and assess whether they have a trauma history or PTSD symptoms, and differentiate whether it meets the criteria of PTSD, of BPD really, whether those 5 criteria that you need to meet to be diagnosed with BPD are met or not. Like no quick diagnosis at first glance for those clients. It's really very important. So the next question would be why it is important to differentiate between PTSD and complex PTSD. What does it give us? What additional benefits we have as clinicians to be able to differentiate them? And one thing, as I said before, is that most things we have as manuals we have until now have been developed for normal classic PTSD. And complex PTSD, and especially childhood sexual abuse, has been associated with a variety of different diagnoses and problems. Like clients show anxiety symptoms, depression, eating disorders, substance abuse. They dissociate more severely. They have low self-esteem, as we said. They may have suicide attempts or come up with a borderline personality disorder. So it is not easy. You have like 3, 4, 5 diagnoses where you say, oh my God, where do I start? And it isn't usually not as nicely sorted. It more looks like that when you see them. And it's really hard to get an idea, where do I start with them? Because there are so many problems and so many areas that are problematic that clinicians get overwhelmed. And in the end, they do not do the trauma treatment. That's, in Germany at least, that's usually the case, that those clients do not get treated properly. They only get like stabilized, they get medication, but they never really get treated for PTSD. And that's a big shame and problem. If we look at those clients, also to see why it is what's different with those clients, because the complex PTSD clients are also different in the way they react to us. They are more like mistrustful. They are they are not as open as you would expect from normal PTSD clients. I have treated complex PTSD clients and classic PTSD clients, and I have the feeling that the complex PTSD clients have difficulties to come into the setting and see me as a therapist. They are usually also difficult in the therapeutic relationship. And it is very, it may affect the treatment if you don't know why it is happening and can't make sense of it as a therapist, as a clinician. And some may interpret it as commitment problem, not willing to work with you. So that's why it is important to see the history of those clients and what they bring with them and where they come from. In contrary to normal PTSD clients who may have had like very normal upbringing. So those are like healthy controls. We made a study in Mannheim in Germany, where we compared healthy controls with somatic disorder clients and BPD clients, and regarding their traumatic experiences. And like the healthy controls, 75% said they have never experienced anything distressing. 12% said they had been sexually abused, 9% said they had been maltreated, and 8% said they had experienced violence between parents. The somatic disorder clients had very similar picture, like 70% said they had never experienced anything traumatic, 15% had been sexually abused, 9% had been maltreated, and 12% had experienced violence between their parents. And this is the picture of borderline clients, where only 14% said they have never experienced anything traumatic, and 60% said they had been sexually abused, 39% said they had been physically abused, and 39% experienced like domestic violence. And yeah, if you look closer, like 86% said they had been emotionally neglected. On top of being sexually and physically abused, maybe. So this is like the biography that is not that easy. And if you think that they have to live in the families where they get abused, the family has to or needs to give you support and security you need as a child. And if the family where you're supposed to be secure and safe abuses you sexually and maltreats you and neglects you emotionally, you have a really hard start in life, and trusting people will be really hard for you, because you understand, like, people who were there or had to be there for me were not. How can I expect other people who are who I don't know to be good to me? How can I trust anybody in life if my mother, father, and grandparents betrayed me? You can say that, right? So they have a difficult start, and it affects the way they build relationships, also therapeutic relationship. If we look shortly about the prevalence of BPD and PTSD, the prevalence of PTSD in borderline clients in inpatient clients varies from 56 to 58%. So you could say, well, roughly 60% of borderline clients have comorbid post-traumatic stress disorder. It's like 33% of the community sample. And approximately 35% of borderline clients have a comorbid borderline personality disorder. So in that sense, if you have borderline clients, you need to check it for PTSD, because like 60% is quite high. So you can expect like every second borderline client to have a comorbid post-traumatic stress disorder. Yeah, this is one important aspect. Let's look at those core features of complex PTSD. I talked a bit about that earlier, but we have like 5 core features. Earlier I talked about the diagnostic criteria of ICD-11. Here we have like more core features. Like one core feature of complex PTSD is, as I said, problem in emotion regulation, in self-identity disturbance, social interaction, memory processing, and body perception. That is not part of the diagnostic criteria, but it's also part of the disorder, maybe you can say, because most complex PTSD clients have difficulties with their body perception. They don't like themselves, and connected to that have also difficulties with sexuality, for example. So it is also a complex thing in itself. Yeah. That's what I said, why we need, why it is important to know or to be able to diagnose complex PTSD, or it is important that we have a diagnosis, and I hope more and more treatments will be developed for the diagnosis. As before that, every evidence-based treatment has excluded clients with substance dependence, suicidality, or like most, not every, but most, bipolar disorder, substance abuse, depression was like less. But the dependence, suicidality, self-mutilation has been excluded really continuously from the evidence-based treatment research. So you can't really say that clients, the manuals can be used for those clients as well. And you usually see, I think, it is even said in the manual of, in PE manual, for example, it says explicitly you can't use the program if clients are self-harming and suicidal. But what do you do with them? That's the question. If I can't do it with self-harming clients, both complex PTSD clients are self-harming and suicidal. So one thing would be to think, okay, why don't we use standard DBT, as the complex PTSD seems to be very similar to borderline personality disorder, and also with this problematic features. It's similar, even if it's not the same. We could say we can use standard DBT as a very well-established program for borderline personality disorder. And this is why not, as 87% of the PTSD clients did not get better after standard DBT treatment after a year. So only 13% had met the criteria of remission, and 87 did not. And usually you have 56% of remission rates when you do trauma-focused treatment. So the data shows if you only do stabilizing work, that would be also DBT, like teaching clients skills, how to cope with their emotional disorders or this kind of problematology, the symptoms, the trauma symptoms do not get better. That is maybe important to put it in that way. And we know it does not matter what you do. If you do not do a trauma-focused treatment, the symptoms will not get better. And even more, those clients do not or do worse in the inpatient or also outpatient treatments, like DBT treatment. So clients with PTSD, and more so complex PTSD, with comorbid borderline personality disorder do not do well in DBT treatments. So if you have clients with complex PTSD disorder and borderline personality disorder, I think we will give them like DBT for a year, and then we can see when they have got better, we will do a trauma treatment with them. It may be a trap, as they do not really profit from the treatment. So you have to look closer and see how much of DBT does the client need to be able to do the trauma treatment. So not this kind of first we stabilize and then we do trauma. Yeah, I will skip that. one thing I also wanted to focus on, I'm looking at time, we don't have that much left, but one thing I wanted to focus on was also the aspect of importance of shame, of guilt, shame and guilt in complex PTSD clients, as these are two major emotions that get into the way of trauma treatment usually. And even though guilt may also be a problem with normal or classic PTSD clients, it's usually more prominent in complex PTSD clients. And if you do not work on guilt, treatment like exposure treatment may not work. So it is a very important emotion to work on before you go into the exposure treatment with those clients. So as we talked about interpersonal violence and neglect in the families, this activates the need to protect themselves in clients. So the anxiety, fear, pain they have activates this fight-flight reaction and the need to feel secure, right? And the question, why does it happen to me? Why aren't they so mean to me? And but the clients are not able to do that. They are not able to get themselves in a secure place. They are not able to leave the families. So they have to stay in the family, stay attached to the family, love their mothers and fathers. Otherwise, they will not survive, right? So how do they do that? They say, it's up to me. It is my fault that happens to me. It's not the fault of my parents. They are doing everything right. It is happening to me because I am bad, because I deserve that. I do not deserve anything better. This is the psychological way of children to deal with their experiences. And if you can imagine, if you have thought about in that way for like 10, 15 years, this pattern does not stop when you get 18 and maybe the trauma stops. It goes on. And in addition to that, when the PTSD symptomatology starts, sometimes it does start later in the after the trauma has stopped, they interpret their behaviors in the past as if they wanted that, or they cooperated with the perpetrators, so they feel even more guilty, and they say it is my fault completely. And you have clients who say it is 100% my fault that my father abused me sexually when I was 7 years old, and they don't want to change that idea. So you may see where there is a problem, because you can't work on any emotions, and it is emotional problem. You can't really feel any grief, any helplessness, any of those more vulnerable emotions if you feel guilty and are ashamed. It's like a it's like over those emotions, stopping them to come through. So we need to, or you will need in the treatment to target shame and guilt first, especially with the complex PTSD clients, to be able to get to the more vulnerable emotions you want to process later. I will skip that. Yeah, you have the emotions complex PTSD clients usually experience, right? The black diagrams like disgust, guilt, shame, anger, sadness, distress, fear, helplessness. So you have a variety of emotions, and it is not only about fear. So targeting the habituation and saying we need to habituate the fear, and then we will get rid of PTSD is not right for complex PTSD clients. There's more. Yeah, so we have the dilemma of saying before. Now we have always said we need like a stage treatment. In the first stage, we focus dysfunctional behavior with complex or with these kinds of clients, and then we focus PTSD and do trauma-focused treatment. But it does not really work, because the complex PTSD clients use their behaviors, as I said, or the dysfunctional emotion regulation problems, or the self-harming, suicidality, dissociation, are a means to cope with the intrusions, cope with the emotions that are connected to trauma. So you cannot really take that away from them and then do trauma like a few months or a year later. It has to be done differently. So, and that this is what the big problem is, right? You, in difference to BPD clients who use, for example, self-harming to regulate their emotions, and they are very thankful if you tell them their skills to regulate your emotions in a different way. Complex PTSD clients are not that thankful, because if they do skills, they notice that the intrusions get more intense and they can't cope with them better, and they relapse usually and harm themselves again, because self-harming helps them more effectively to cope with the intrusions than any skills you can teach them. So without telling them that the trauma treatment will come a few weeks later, they are not able to keep that level of using skills and putting up with the intrusions. That often gets problem with those clients. So we have a problem there. Yeah, this is, so to say, yeah, that's that's what I wanted to tell you about the complex PTSD and BPD and the treating, or maybe you get notion of where the treatment of those clients should go. That was from me, and now I'm very curious. Maybe we have some time for your questions. I will stop the presentation, and so you are able to see me and I'm able to see you.
Yeah, thank you, Tamara. Thank you for a wonderful presentation. Does anyone have any questions for Tamara?
I have one.
Yeah, thank you, Bob.
Hi, Bob.
Hi, Tamar. How are you?
I'm fine, thank you. Nice to see you here.
Nice to see you, and congratulations on the second child.
Thank you.
You know, the woman who heads up our institute is also involved in this. I saw her name was in there, Jackie, but I showed her the electronic version of what Martin had sent me for the workbook. And I'm still very interested in implementing that. And as you were reviewing the difference between PTSD and complex PTSD, it became very apparent that the clients we're working with all meet the ICD criteria for complex PTSD. And so I just wanted to give you a heads up that I'm probably going to be getting in contact with you so that I can talk with you and bring the co-facilitator in with me so that we can get this started.
Yeah. Yeah, this is Ms. Shepp. You wrote a comment how to keep a balance between good therapeutic relationship with PTSD clients and unhelpful dependency. How to say? I think the problem with trauma is that clients and therapists usually have a bit of an O maybe for trauma and think it is something really bad, and have maybe compassion, a big compassion toward the clients. And we try to not to overwhelm them and to protect them. And this is the tendencies clients, a therapist notice in themselves when working with trauma clients. And the problem is that those tendencies do not help the clients. So you can build a good relationship if you treat them as people who can put up with what happened to them, and who have the strength to deal with what happened to them and go through the treatment. And it's a really important stance, I think, from the therapeutic perspective, that you always make sure you believe in the client. And a good relationship, I think, does not necessarily need to be this feeling sorry for the client and protecting them in that sense, right? A good relationship is this transporting this trust and this belief that the clients can overcome trauma, and this way leading them to the trauma-focused treatment. And it helps not to get them dependent on you. So it's then you do not get in this dependent relationship where you only protect as a therapist. Right? I think that is an important balance, and I have seen many clients being thankful that therapists like me and others, my colleagues, are very straightforward and motivating. You do not want to overwhelm them, but you want to motivate them to confront themselves and do the treatment. I think that would be my comment on that. So.
Yeah, great. Thanks, Tamar. Does anyone else have any? Dr. Dewars, do we want to ask anything, or?
Yes, Tamar, I want to thank you for helping conceptualize very clearly some complex information, and to also very succinctly focus on the appropriate steps by which to organize a treatment plan. And also adding your own clinical experience is a very great benefit as well. So I want to thank you personally for starting this lecture series. And as we learn more about schedules, we'll certainly inform the people in this group about those schedules and availability. And we look forward to seeing people again.
Yeah. So I think one last word maybe from me, because I hope it came over clearly that the last slide was also saying that what we have done before is not enough, and we need new treatment methods where we combine the problematology that the clients bring with them with the trauma-focused treatment. That's what is needed. And that's what PTSD does, basically, but I'm sure it will not be the only treatment that combines those two problem dimensions. Yeah.
And as a quick aside, Dr. Lang and I started a federally recognized nonprofit. It's called a 501c3 to develop innovative treatment plans for complex PTSD. That nonprofit is, in fact, partially funding our activities today, and we certainly look to talking with you and coordinating with others our own concepts about innovative treatment for the future. Again, thank you, Tamar.
Thank you all.
Thank you, everyone, for being here.
Yeah, thank you. Thank you for asking questions. What I would like to say is we will try to put these lectures in a format that's available for everyone who would like to review them later on, or for people who could not actually make our session this morning. So they should be available, and we'll inform you over the email. Thanks, everyone. If there isn't any questions, then I'm going to conclude the session.
I had one question.
Please.
As far as treatment, is treatment equally as efficacious if it's individualized versus in a group setting, or is one or the other more advantageous?
Well, there are not many treatment plans for group treatments for complex PTSD and PTSD as well. So I would say you can do group treatments like additionally, like skills training, for example, in a group setting, but trauma treatment, trauma-focused treatment needs to happen in an individual therapy. Yeah.
And can that happen remotely, or is it better to do that one-on-one and
in person?
face-to-face?
Yeah, I would say it is also possible to do remotely with a big but if we are talking about the complex PTSD clients with the severe emotion dysregulation problematology like self-harming and suicidality, I would not recommend doing it remotely only. Yeah. Because you need more hold of a client to feel secure as a clinician to do the exposure treatment and trauma-focused treatment.
Yeah, that makes sense to me. Thank you. Thank you.
Thank you for your question.
Yeah, thank you, Herb. If there are no other questions, I'm going to conclude the session this morning. And thank everyone for participating, and thank you again, our Tamar, for giving us wonderful, informative lecture.
Yeah, thank you all. Have a nice day.
Thanks, everyone. Bye.
Thank you.